Hello and welcome to today's lecture regarding the abdominal assessment. I would encourage you to review your anatomy and physiology prior to proceeding with the rest of the lecture.
In terms of developmental competence for infants and children, note that in the umbilical cord itself, there are two arteries and one vein. And the way that I remember this is AVA, AVA, two arteries and one vein. And also notable in small infants is that the liver takes up proportionately most of that abdominal space. But as they get older, it will start to become more in relation or in the same scale of that of an adult patient. And healthy term neonates or newborns, that lower edge is actually palpable up to even 2.5 centimeters below that right costal margin. So remembering that the liver lays under that costal area, but just a little bit can be palpable. Also, in smaller children, the urinary bladder is located a little bit higher than you would expect in an adult. And so when you're palpating, keep that in mind as well, especially if you're trying to assess for a distended bladder or so. It does lie between the symphysis and the umbilicus. Now, if you've ever felt a baby's abdominal area, it's very pudgy. And this is because the infant and children in general just have less muscularity in that abdominal wall. And so during early childhood, as you're poking around, you might be able to appreciate the organs much better than that of your adult patient. Some things that you want to consider for a pregnant woman is that just in terms of just the GI system itself, we're thinking in terms of what might be causing nausea and vomiting in a pregnant woman, and this is a pretty common chief complaint or reason for seeking care in this population. And it usually starts during the first trimester and maybe even into the second. If you're lucky or fortunate, it should go away. But some women will experience it throughout pregnancy and at different severities as well. What some people think, although it is not completely known, is that this increase in GI symptoms is due mainly to hormonal changes. And this is because of the production of human chorionic gonadotropin. Another symptom that is very common in pregnancy, and this is due to the displacement of the GI organs, is acid indigestion or heartburn. And so there's old myths of stomach discomfort and heartburn being associated to having a baby with lots of hair, but really it is very common just due to the anatomy and the physiology of pregnancy. It is related to the displacement of the GI organs. And we also have a situation where pregnant women will increase their risk for constipation due to decreased GI motility, again, due to displacement. And it just takes longer for gastric emptying to occur. And this can happen during pregnancy and shortly after that postpartum period. Another thing to think about is just because of this decreased motility, more water is absorbed back into the colon instead of being inside the intestines itself. And so that is what leads to the constipation that women experience during pregnancy. Here you see that this increased pressure also leads to increased risk for hemorrhoids because of the pressure onto that lower GI area. And bowel sounds can sometimes even be diminished, if not displaced, because of the way that the uterus is lying over the abdominal area. And this is also dependent on the size of the baby and what term that you are in your pregnancy or your patient is in. And this can happen with many organs. Another thing to remember is the skin changes that were involved. And we talked a little bit about this when we talked about hair, skin, and nails, but don't forget that there are skin changes um, over the abdominal area. The main one being striae, but often we will have a darkened um, hyperpigmentation that occurs from just about the xiphoid process all the way down to the suprapubic area. And this is called the linea nigra. With older adults, we are thinking in terms of, what is aging do to us? And that abdominal wall is greatly affected by aging. We lose again some of that musculature, and it does alter the overall appearance. Additionally, we are at risk for dry mouth and a decreased sense of taste, mainly because our salivatory glands are decreased in their function as well. Additionally, I would think in terms of dry mouth, you want to consider the medications and maybe the polypharmacy that most of our aging population is affected with. So many of their medications may lead to dry mouth as well. Now, changes of the GI system will occur with aging, no doubt, but most patients are not significantly affected unless there is a chronic or acute GI disease that's present along with it. We do know, however, that esophageal emptying and gastric secretions become delayed, and you are at risk for gallstones as you get older. Now, there's a certain population that is more at risk, 40 female fertile fat, and that's the way that most people remember it. But basically, if you are an overweight female over the age of 40 and you have multiple children, you are at risk for gallstones. We also know that as we get older, our liver will slightly decrease in size, although we expect our liver function to remain normal. Now, that's not to say that if you have liver disease, that your liver function will be normal, but we don't expect a normal aging patient without any GI disease or liver disease to be affected with their liver function. However, many are, and so we pay careful attention to the medications that are being metabolized through the liver because of this. Aging adults, again, also report constipation as well, and it's due to delayed gastric emptying and slower motility. Now let's move on to the subjective history. We'll first start with interviewing our patient and what type of questions might we ask that are directed to majority of their chief complaints here. So we're going to first start by thinking about what our patient tells us when we're asking them about their appetite, their eating habits. Are they experiencing any changes in their appetite, what they're able to eat, what they enjoy? Are there any recent changes to weight gain or weight loss? And are they intended or not intended? How long has this weight gain or weight loss occurred? And what are they doing if they are dieting? Are they dieting safely, or are they binge eating and then dieting and restricting food? So you're trying to get an idea of the pattern of their appetite. Also, I want to bring your attention to this term dysphagia. And dysphagia is different than dysphagia with an S. Dysphagia with a G is talking about difficulty swallowing. And you want to ask them, when did you first notice this? Are you creating more saliva or not enough? Is it happening with thick fluids or thin fluids? Getting the characteristics of why and what they are having difficulty swallowing. Additionally, because we are talking about the GI system, we need to ask them about any food intolerances. Are there things that you are known to be allergic to, things that you may be sensitive to when you eat? What happens when you eat these foods? Is there an allergic reaction versus stomach discomfort? Does it increase bloating, distension? Do you have increased gas in your intestines? Does it cause heartburn? And then After you've old cart these symptoms, you also want to ask what type of medications are you using? What are you doing for relief? What makes it worse? What makes it better? Now, for abdominal pain, this is a symptom that you'll come across with many of your patients. And what I like to do is ask them, please point to it. Can you show me in just one spot or a couple spots where you're experiencing this pain? And sometimes they're not able to, and they will move their hand, all around their belly. And so you want to think of that in terms of generalized pain. But often they are able to isolate it to one or two areas. You're going to old cart that symptom. When did it start? How long have you had it? Does it come and go? This is really important. Is it constant versus intermittent? Does it occur during certain times of the day? Is it after you've eaten a large fatty meal, or is it even before, or maybe during? How would you describe this pain? Ask a very open-ended question first, and if they're not able to find the words to describe their pain, then you can give them some examples like, is it burning? Is it cramping? Is it dull versus sharp? And you want to ask them if their pain is actually relieved by food or worse after eating. And this is important because sometimes pain is due to increased gastric acid. And sometimes as we're eating, it helps to decrease the acidity that we're experiencing because the acidity is now breaking down food. So this will help to eliminate some GI issues versus the other. One additional thing that I want to draw your attention back to is that sometimes abdominal pain is actually a sign of cardiac pain, especially in women that don't present the textbook way. So you want to make sure that you are also eliminating that from your differentials. Pain can also be associated to menstrual cycles, irregularities. We also can appreciate abdominal pain when we are overly stressed or when we are eating things that we shouldn't be eating, or maybe restricting ourselves from eating things that we need. It's often associated with fatigue, nausea, vomiting, increased gas, fever, rectal pain, frequent urination, or vaginal or penile discharge. So just because it's presenting as abdominal pain, it may be referred pain from our other symptoms, or our systems, like our GU system. So again, you're just going to ask, relief and what makes it worse and what you've tried in the past. For medications, you want to get a detailed history. Maybe they are taking antacids or over-the-counter medications like Tums or Pepto-Bismol, and you want to ask them how long they've been taking it, how much, what's that dose, and how often they are taking it. So many people abuse over-the-counter antacids, Tums, and anti-constipation medications because they are not going to see a provider to get their treatment, but they're trying to find a short term or an easier way to treat their symptoms. And they may be taking too much too fast or not enough, or they're co-mingling medications that may worsen their symptoms as well. Here are some common sites of referred pain that you can see here. And I'm not testing you on, if you feel pain in the left arm, what do you think this patient has? But that's not what we're going to do for our exam. However, I do want you to see this so that you can start thinking about common areas that you might experience pain that has to do with the GI system itself. So again, I just want to direct you to the worst case scenario. So, if they are having GI symptoms, it could be GERD, but it could also be chest pain, and then vice versa. They may have chest pain and it could be GERD, but it also might be real acute chest pain. So make sure that you are really thinking about what's that worst case scenario, what other organs or systems that pain may be connected to. Specifically with our complaint or symptom of nausea and vomiting, you're going to ask how often this occurs, what time of day this occurs, What is the quality and the characteristic of the vomiting? How much is actually coming up? Is it partially digested? Is it bloody? Do you feel colicky and uncomfortable with your pain with vomiting? Do you have nausea, diarrhea, fever, and chills? I also want to ask what they've eaten in the last 24 hours, trying to eliminate that it may be some type of gastritis or that they've experiencing some food poisoning. And you want to address the question of what they were eating and where and who were they eating with. And so if it is something related to a food poisoning type issue, then we need to start figuring out, is it bigger than just a household? Did it happen because they were at a restaurant or a public area? And this becomes a public health concern. And now we're going to talk about just bowel habits. And so, as you continue with your nursing career, it ends up being a little bit easier to talk about bowel habits. But in the beginning, it's kind of weird and you feel invasive, but get comfortable talking about patients' bowel habits. Ask them, how often do you have a bowel movement? Sometimes they might not know what you mean when you use that terminology. You might have to just say boo. Ask them what color, consistency. Is it more constipation? Is it diarrhea? But if you are very uncomfortable asking these questions or they seem very uncomfortable, I like to use the Bristol stool chart. And this is what you see here that choose your poo. And I use this often with my practice in both pediatrics and older adults. And I just ask them, what type, tell me what number, or point to the picture. And it ends up being a little bit more easier to talk about and describe. It's a little bit uh, easier on the ears too to point to a picture versus hearing your patient describe what their poo looks like. You also want to talk about laxatives and, constipation or anti-constipation medications. Are they using a stool softener? How often are they using them? How long has it been? And are they effective or not? And this goes back to their diet as well. Then I'm asking them about abdominal history and other GI history, trying to find out if there's any history of GI disease. Are there risk factors for GI disease? And I will ask them specifically, have you ever experienced an ulcer or gastritis? Have you had your gallbladder removed or has it been inflamed? You're looking for signs of jaundice. You're going to ask them, do they have a history of jaundice, hepatitis? Thinking about their risk factors for hepatitis, appendicitis, colitis, hernia. In our older patients, you might even ask them if they've ever had a colonoscopy. Although if they have a family history of colon cancer, they're not going to be 50 when they get their first colonoscopy. They might be much younger. And so don't eliminate that question just because you're assuming their age. You also want to ask them about the surgical procedure itself. Were there any complications? Did they require additional stay in the hospital, something that didn't go as planned, drains, ostomy bags, any abdominal x-rays have they received because of maybe past GI complaints. You want to know approximately when and what the results were for each of these areas. Now looking about medications specifically, I want to know what they are currently taking as their everyday regimen, what they take when their GI symptoms erupt, and also I'm asking them about antibiotics. And so one medication that we use quite often to treat um, H. pylori infection that causes GI symptoms is an antibiotic. And I want to know if they are drinking alcohol because they shouldn't be on an antibiotic. But also, I'm asking about alcoholic beverages too, because it could exacerbate their symptoms and actually cause some of their GI symptoms as well. And this includes smoking in addition to medications. I'm also going to do a thorough nutritional assessment, not just asking them what food triggers they have, but just trying to get an overall look at what their common routine is in cooking and what type of food that they are eating on a consistent basis. This is an opportunity for you as nurses to look at your patients holistically too and consider the determinants of healthcare that we think about, or determinants of health that we think about in the sphere of public health. And you might want to address questions about food disparity and ask them, are you having difficulty preparing healthy meals? Uh, have you ever felt in the last month where you were struggling to eat healthy because you just didn't have the resources to? Are there fresh markets in your neighborhood, or um, do you have the ability to eat the way uh, we as healthcare providers are asking them to do so? Because sometimes it's not a lack of knowledge; it's actually a lack of resources. Additionally, for infants and children, I want to know specifically what they're eating, how much. For infants, if they're bottle or breastfed, how many times per day, how many ounces, or how many minutes if they're breastfeeding. I also want to know for toddlers, are they picky? Do they eat regularly, or do they kind of graze? Do they eat all the food groups? Do they have a diagnosed eating problem? Additionally, just like we did with adults, we need to ask them about their poop habits as well. So you're checking for constipation, also for diarrhea. I want to know how much water they're drinking, especially compared to juice in the child's diet. I also ask how many sodas or sports drinks or anything besides water that they may be drinking. I'm getting a 24-hour food um, a log as well from these parents, but also, just in general, how do they eat? Because this could be contributing to their abdominal pain and constipation. I do see a lot of patients that have uh, chronic withstanding abdominal pain, and it's because of untreated constipation. Talking about weight is a little sticky, even, talking with adults, but it ends up being even more uncomfortable sometimes when you have to tell somebody's child or tell the parent of somebody's child that they may have an increased BMI and they are overweight. And so you want to show them the numbers, help them to come to the conclusions themselves, let them know what the normal ranges are, and give them ideas of how we can change little by little the pattern of their eating habits. Now, if this seems a little bit overwhelming to you, it is your job to plant that initial seed and to help the parents just to see what is what, but don't feel like you are by yourself. You can always help with the interdisciplinary team by creating the plan or consulting with somebody that knows a little bit more about dietary habits and motivational interviewing to help parents and patients to understand that there may be a problem to address. Additionally, for adolescents, it's very common for this age group to have irregular eating habits. I specifically want to know, are they eating meals versus snacking? What types of snacks they're consuming, calorie consumption versus exercise pattern, and something else that you might want to ask them, ask the parent separately than the adolescent itself. This is a period where eating disorders can become prominent, and you want to get an idea based off of the adolescent's perception, but also the parent's perception as well. I might ask about menstrual irregularity, because if you're not eating well and taking care of yourself, whether you are under consuming calories or over consuming calories, so whether BMI is high or low, this can alter your menstrual cycle too. For our oldies but goodies, now last but not least, I am thinking in terms of chronic disease, but also ADLs. Are they preparing their meals? Who they live with? So I'm asking about the social history. And all of this is because if they're unable to make meals, they are not going to get the nutrition they need, or they may be substituting the good nutrition for easy, fast food that may get them the calories that they need, but maybe not being nutritious. If they live by themselves, they may not eat as much, so if you notice your own eating habits, I'll pick on myself, but when I'm sharing meals with other people, I tend to eat more because we are um, enjoying each other's company, staying at the dinner table a little bit longer, going out. And so you tend to consume more calories. Where for aging adults, if they don't have anybody living at home or they don't have caretakers that are home with them, they may not have the same nutrition that we do or the nutrition that's adequate to for their disease or just overall health in general. So I might ask some questions like, what did you eat yesterday? Do you like to cook? Who cooks at home? Who lives at home with you? And then, of course, because we know that constipation is an issue for our older adults, I'm going to ask them questions about their bowel movements. And specifically, I will ask them, do you have any trouble swallowing foods? And if they complain about pain or discomfort, what do you do after you eat? As we get older, I've noticed that many of my patients, they tend to take naps during the middle of the day, but this might increase or exacerbate any of their GI symptoms that they might have. Okay, go ahead. You can pause the recording for a little bit, take a little stretch break, and when you are ready, you can come back and we're going to talk about the objective assessment. Okay. In preparation for your objective assessment, you want to make sure that you have really good, strong overhead lighting, and you might even require secondary light. It could be a pen light if it's just a small area, but also a stand light with maybe a gooseneck arm, so you can really focus on the GI system in the abdominal area. Make sure that you are exposing the abdomen as much as possible, that it's fully visible for you, and you want to drape your patient appropriately, and you want to position them for relaxation. So when they're supine, don't want them to be completely supine. Have them just bend their knees just slightly so that they're comfortable. What's really important too is having them empty their bladder before an examination. And this is true for your partner as well in lab. Make sure that you are comfortable before you start tapping around and pressing around because we will be palpating. Make sure your stethoscope is warm and clean. And really important is that you wait to observe, to palpate, and to listen to the areas that are painful last. Because if you start with the area where your patient describes as being painful, then you limit the rest of your assessment because now you exacerbated that area. Now, sometimes it's impossible because they're already coming with so much pain everywhere. So you do your best, but just keep that in mind. You will auscultate before you palpate and before you percuss. And the reason why is important. And I'm going to have you think about that for a little bit and we'll discuss it further on in the slides. But this is the one system where we go out of order. So after we inspect, we will auscultate. You will have your stethoscope. We use primarily the diaphragm, but we will be using the bell to listen to vascular sounds and making sure that you have some type of measurement tool in case you come across something you need to measure. We'll find out soon. And an alcohol wipe to clean the end piece of or your diaphragm or bell. So initially you're going to inspect the abdomen overall, and we're just looking at the contour and the symmetry of the body. You want to stand on the person's right side. You want to get to the level of the abdomen, just a little bit above and look down. And you want to stoop and sit and gaze across the abdomen. And you're looking for symmetry. You're making sure that the contour is consistent across, and you're going to determine that contour, checking the profile from the rib margin, the costal margin, all the way down to the suprapubic area or the pubic bone. And the contour is going to help to describe the nutritional state of the patient. And this can range from flat to rounded. You'll see in the next few slides, even scaphoid or protruding. You're checking for symmetry by shining a light across the abdominal area, and you want to make sure that it is symmetric bilaterally. Here are 4 examples of ways to describe contour: protuberant, scaphoid, flat, and rounded. And flat and rounded are usually what you'll see most of. So make sure that you're charting appropriately and be familiar for these types of contour configurations for your exam. You're also going to inspect the umbilicus and the skin. So we know that we inspect skin at every juncture of our body, and you're looking for a smooth, even, homogeneous color appropriate to their race and ethnicity, making sure that there is even pigmentation. And it is a really good area to kind of judge what their baseline pigmentation is. If they protect this area from the sun, but some bathing suits don't allow for that. So you might have to look at a different area to see what that baseline pigmentation is. You're going to check to see if you can see any visible patterns of their venous network. Usually on our thinner patients, we might be able to appreciate that. You're going to check for skin turgor, and you're going to make sure that there are no lesions, scars, no visible masses that you can see, no protrusions, no signs of infection. You're also going to look for drains and ostomies and other types of surgical appliances that may be attached to the abdominal area. Now, moving on to the umbilicus, it's normally midline and normally inverted, although we do know that some people have outies. And we're just making sure that there's no signs of infection, no discoloration or inflammation. And we don't want an outie that's protruding so much because that could be a sign of an umbilical hernia. We're checking to see if the umbilicus is everted or pushed upward, and this usually happens during pregnancy because of the displacement caused by the growing uterus. The umbilicus is a common site for piercings, and so you want to make sure that there's no infection there as well. Moving back to skin, just drawing your attention back to the term striae, which we know are stretch marks. And earlier we found this in our pregnancy slide. However, it's not just pregnant women that deal with striae. It can be found in all types of habitus, every type of person. And so basically, it's just a change in pigmentation, usually linear and silvery white and jagged. They are probably about 1 to 6 centimeters long, and this can occur due to the elasticity of your reticular layer of the skin. So sometimes it occurs on some people and not others. It really doesn't, you can't really determine who will have striae or not. Sometimes it's only during pregnancy, but also during periods of rapid weight gain or loss. You're also looking for pigmented nevi or pigmented moles. Usually they're circumscribed, they're brown, they're flat, so they're macular, and they can also be papular as well. These are very common around the abdominal area. You will use your ABCDE mnemonic to make sure that there are no signs of concern. And if there are any lesions or masses that you can appreciate, make sure that you are charting that appropriately. Other things that you might note are surgical scars, whether they're fresh open wounds or they may be old scars from previous pregnancies, C-sections, or from previous abdominal surgeries. Here are some examples of other types of abnormal findings or normal abnormal findings, or findings that are just not expected. And so take a look at these things. You might see some purpura, which here it's a Cullen sign, which is a sign of liver damage or disease. You see a gentleman here on the right side of your screen with striae, infected piercings, pregnant woman with just a little bit of the beginning of maybe a linea nigra, but I don't see any striae here. And then the gentleman on the left with pronounced abdominal muscles. If you see a scar in the chart, even if it's an electronic chart, there is an opportunity to pull up a schematic where you can delineate where that scar is located and measure approximately how long and how wide. You often find that as you're doing your interrogation or your interview with your patient in the beginning, in that subjective section, they may totally forget about any surgical procedures they've had. Many times, women that have had C-sections just forget to bring that up because they don't really equate that to being an operation, although it is a major abdominal operation. You want to confirm what they're saying by what you are seeing. And so, whether they forgot to tell you or not, you're going to know when you start assessing the skin area of the abdomen. In addition to inspecting the skin area, you're going to look for pulsation or movement. And the area you're paying attention to is that aortic area. And as I said earlier in the lecture, it's just left of midline. And you're looking at this epigastric area. Usually with thin persons, you're going to be able to see it a little bit more. And if your patient is relaxed, you'll be able to see it more. And sometimes you can't see it at all. What's more important is how wide you're seeing it. And we're going to get there in a little bit. You're looking for hair distribution and you're looking for the demeanor. Now, a patient with abdominal pain or they are, concerned, they will feel a little bit uncomfortable when you are examining them. And so check their facial expressions, check how tense they are. And if they're doing any guarding, and guarding is, when they take their arms and try to cover their abdominal area because they don't want you to touch them or they anticipate pain when you palpate. So there is a point where after you're inspecting, you're going to go right to auscultation. And you're auscultating for two things. The first one is bowel sounds, and the other one is vascular sounds. Bowel sounds will always be auscultated with your diaphragm, and vascular sounds are, auscultated with your bowel. So this is done because you don't want to percuss and palpate first because it's going to increase peristalsis. And this is going to give you a false interpretation of what you're hearing. So you always start with auscultation. You're going to use your diaphragm, and you are doing this because bowel sounds are very high pitched, and your diaphragm is the best tool to appreciate these sounds. You're going to hold your stethoscope lightly against the skin if you're using a traditional stethoscope. You don't want to push too hard because this can stimulate overactivity of bowel sounds, but you don't want to hold it too light that you're not hearing anything at all. You're always starting your abdominal assessment at the right lower quadrant, right above that ileocecal valve. And this area is where bowel sounds are normally always present. And you're going to move from that right lower quadrant to the right upper quadrant, and then the upper left quadrant to the left lower quadrant. When you're listening, you're going to note the characteristics and the frequency of bowel sounds. And you're going to think about, when you're listening, do you hear it gurgly? Are they very hyperactive or very underactive? And the only way to know that is if you listen to a lot of bowel sounds, you can start to understand like, oh, this is really a lot of bowel sounds compared to this last patient that, I didn't hear very many bowel sounds. It's also attributed to the time that you've last eaten as well. And so for many students that come in after lunch for lab, you might have a little bit of overactivity because your GI organs are breaking down food. Bowel sounds are high pitched, they're gurgly, they start a cascade, they go up and down, and they're very irregular. It's not like a heartbeat or respiratory rate. They're very irregular, and usually they're about 5 to 30 times per minute, and that would be your range of, is it hypo or hyperactive? Don't count them though. We're not counting them. It's more of a subjective interpretation. Now, there is a term that we use to describe the sound of hyperperistalsis. And this term is borborygmus, a term that I like to say. Thought it was really fun to say in nursing school as well. There's also a term called silent abdomen. And this term I don't use unless you have listened for 5 minutes and hear nothing. Okay, and this is not 5 minutes in one place. It may be 5 minutes as you're moving your stethoscope from one quadrant to the other. And if for 5 minutes you hear nothing, then you can term it silent abdomen. It is something that you would want to discuss with your team as soon as possible because it may be a sign of obstruction or some type of other really pressing GI complication. When you're done listening to abdominal sounds with the diaphragm, then you're going to switch over to the bowel and you're going to listen at the sites for vascular sounds. Although this schematic is showing you where there may be sounds at the femoral and iliac arteries, the left renal artery, in lab, I only want you to assess for the aortic sound. You're going to use firmer pressure over the aorta, left of the umbilical line in the epigastric area, and you're listening. Sometimes you can hear overactivity here in people with hypertension, but usually no sound is present at all. If you do hear a sound, you want to pay attention to that because that sound that you're hearing is can be a sign of a bruit. So listen to see if it's truly an increased vascular sound and differentiate that from a bowel sound. Now we're going on to percussion, and percussion of the abdominal wall is by far way easier than the respiratory system and, percussing over the lungs and thorax. And it's something that you will do commonly in practice as a nurse, more so than the respiratory system. And when you're percussing, unlike the respiratory system where we're percussing and the sound we're hearing is resonance, the sound you're trying to elicit as a normal sound is called tympany. And you might hear tympany over the majority of the areas, but over the liver or the spleen, you might hear dullness and even over constipation. But you're percussing to remember the reason we percuss is to assess the density of the organ below or the area below. We're checking for the density of the abdominal contents. And so if you're hearing dullness throughout the abdominal wall or the abdominal cavity, there's a good suspicion that this patient may have constipation, but depending on the type and the quality of the sound you're hearing, it may be that there's free fluid surrounding their peritoneal area as well. You also might be percussing right over a mass that may have been unknown to them because it's not protruding outward. So how do we do this? We start always again by the lower right quadrant and we're going to move in succession. And you're going to determine the sounds of tympany versus dullness. And it's not, one or two taps in each quadrant. You're just moving it kind of in a zigzag pattern. And there's no real pattern, just where your hand kind of takes you. But you want to go over the majority of the surface area, always moving clockwise. Now we're going on to special tests that I want you to understand, though we're not going to test you in lab and you're not going to perform this in lab. And the abdominal assessment has many of these tests. And so I've put on the slides in yellow on the top, which ones are not going to be tested. So you can also, because we're percussing to understand the organ density below, you can actually percuss to map out the boundaries of these GI organs. And so with the liver span, if you choose to do so, you would percuss using the right midclavicular line, and you're going to move into the intercostal spaces because that's where you're going to hear the difference. And then you are going to mark that area where you hear the difference between dullness and tympany. Then you're going to go inferior of that area from below, and you're going to do the same thing. And that area is going to show us the span of the liver. And sometimes you can hear it better going from the top, and sometimes you hear it a little bit better from the bottom. But that point midway is going to help you to determine that span of the liver. Here you can see that they are marking the spot. Usually it is the fifth intercostal space, but not always. Everybody's anatomy, again, is different, and depending on the size of your liver. Then you are going to check for the dullness versus tympany. You're still on that right costal margin area. Remembering that the normal liver span is about 6 to 12 centimeters. And you might say, wow, that's a big range. And it definitely is. It could actually double. But you're going to look at it in relationship to your patient. So if you have a very petite patient, should their liver be 12 centimeters? But if you have a very large and tall patient, maybe 12 centimeters is acceptable for that patient. You can also do a scratch test. And so I like this test better than the percussion test. For the liver span, this test is really interesting. I would encourage you to try it in lab, even though we're not going to test you on it. You will need to know these for didactic though. So the scratch test, you will put your stethoscope over the liver area, usually about that fifth intercostal space, right mid-clavicular line. And you're going to start scratching, starting with that right lower quadrant, and you're going to move up progressively. And as you move closer to your stethoscope, it becomes really magnified. And when you hear that point of magnification, you know that you've crossed that border from a hollow organ area to a solid liver area. And then you can tell, how many centimeters it is protruding downward past that costal margin. So pretty interesting. You can also percuss for splenic dullness. This happens between the 9th and 11th intercostal space, and it's on the left. It's being on the left, so left mid-axillary line. Again, not tested in lab, but something that you want to be aware of that you can do. The dullness of your spleen should not be wider than 7 centimeters. And you should ask your patient to take a deep breath in, and then you're going to percuss. And usually tympany should remain when they're at full inspiration. The costovertebral angle is something we talked about last week as being part in tandem of the respiratory and the abdominal assessment. We do this as part of the respiratory assessment because we're from behind and we're already at the posterior side of your patient. However, knowing that you really are doing it to assess the kidneys that lay in the peritoneal space. And so indirect fist percussion, you're going to place your hand over that 12th rib area at that costovertebral angle. Okay, so you're going to outline that and remember your landmarks. That inferior scapular area is at the 8th intercostal space, and then you can kind of estimate or you can feel the spine for that 12th rib. You're going to use the ulnar edge of your fist to thump your hand on the back. And what we're checking for is the presence of possible kidney inflammation, telling us that they maybe have pyelonephritis or kidney infection. Some other things that you can do that are not tested, but I want you to understand is the special procedure for testing for ascites or free fluid that may be trapped in the peritoneal wall. You can do the fluid wave test or the shifting dullness test. And because the abdominal area may be distended during the hospital stay or during their disease process, it may be free fluid that's causing the distension, and it may not be their habitus. And so what we're trying to do is differentiate whether it's ascites, so fluid, versus gas or subcu tissue. So the surface and deep areas of palpation. Before you palpate, you want to be very superficial and you want to start with light palpation and then move on to deep palpation. So you want to get your patient accustomed to being touched in the abdominal area as you're pushing, but also you want to give them time to acclimate and then go in to appreciate deeper areas. You will judge the location and size of the organs below when you do this. You're trying to identify any superficial masses and areas of tenderness, and you're watching for guarding and watching for complete muscle relaxation. I also want to draw your attention back to those two tests for just a second because I forgot that I failed to describe the test to you. But the fluid weight test, you can ask your patient to put their hand midline, just as you see, or if you're working with another nurse or provider, you can ask them to put their hand there. And basically, you're tapping one side and you're seeing if you can feel the fluid bouncing, so to speak, to the other side. The last one, the shifting dullness test, is you're using timpani, or excuse me, percussion to hear, timpani versus dullness and the layers of, as your patient is supine. So you think about a water bottle, if it's full and you put it to the side, all that fluid comes down to the bottom. So that's where that dullness would be expected versus timpani as the fluid is shifting downward. Jarvis has a good description within the textbook and the video as well, discussing these tests a little bit further if you are interested. Okay, so moving to light palpation, you will use your first 4 fingers together and you're just moving down about a centimeter and you're using the circular motion and you're moving it across each quadrant. Not just 1 in each quadrant or 2 in each quadrant, just along the quadrant, starting again from the right lower quadrant. And you're going to lift your fingers and then move them again. You don't want to drag, okay? So you're not pulling their skin. And the objective isn't to search for specific organs per se, but you're just trying to get an impression of what's below. Again, get them acclimated and then trying to find any superficial findings. Now we move to deep palpation. So in terms of how deep, first was a centimeter or so, and now you're going actually 5 to 8 centimeters. And this is because depending on the habitus, you are going a little bit deeper because you're trying to figure out what's below. What are the organs that you're feeling? Sometimes you're feeling constipation. And you're going to use a bimanual technique because you have to overcome the resistance of that abdominal area. So you're putting 2 hands down and you're using that same rotary technique and you're trying to appreciate what is below. So you try to be as make your patient feel as comfortable as possible. But in all honesty, it's a little uncomfortable at times. You don't want to cause any pain, but it's a little uncomfortable. The top hand is going to do most of the work. That bottom hand is relaxed and just concentrating on the sensation of what's below, sensing what you're palpating. And you will do the technique of palpation, again, both right lower quadrant and you're moving clockwise. When you are doing either technique, you are thinking in terms of, the location of what you're feeling, the size, consistency, the mobility of anything palpable that you're feeling, whether it's a mass or an organ. You're asking yourself, does this feel enlarged? Is it a point of tenderness? And is it a point of pain? And if your patient has the chief complaint of pain, then make sure that you're doing the palpation of the area of pain absolutely last. Again, so that you don't ruin, so to speak, your examination by causing so much pain you can't complete the rest of your abdominal examination. Now, in the beginning, everything feels like you're pressing on a sofa cushion. It's spongy with a little resistance. You can't tell what you're feeling, and it will take time and practice. And it really helps to try to memorize and visualize the anatomy below and understand, oh, yeah, this kind of does feel like, the colon, or this kind of does feel like the liver margin. But first, you have to be able to identify where your organs are located. If you identify mass, I need to know location, size, shape. We want to know consistency. Does it feel firm versus hard and unmovable? Is it soft and mushy? Does it feel like it has not, excuse me, is it nodular or does it feel like it has nodes? And I want to know, does it move with your respirations? Can you feel it pulsating? So maybe it's a enlarged aortic artery that is very um, it's very emergent. If it is, you don't want to press too much because again, cause it to rupture. And if there are any signs of tenderness. I left this on your slide if you want just a mental break and laugh a little bit about our profession. Go ahead and play this, and then when you're done, you can continue back with the audio lecture. Hello. Okay. So here are examples of palpable structures, things that most people can palpate when they are doing deep palpation on the abdominal area. If you have a full bladder, if your uterus is a little bit enlarged, most people can feel the cecum and the sigmoid colon. Sometimes you can feel the pulsation of the aorta, like I said. Additional tests can help you find the right kidney, just the lower pole of the right kidney. It's more difficult to find the left one. You definitely need to know the xiphoid process as a landmark, and then maybe you can palpate that liver margin. Sorry. And here you go. Again, making sure you're able to see that all. Take it in. And then these tests again are not tested in lab, but I want you to understand how, if you wanted to palpate the liver, you're going to place your left hand, because you're standing on the right side of your patient, because the patient's liver is on the right, and you're going to take your right hand and you are going to press down. Okay, so your left hand is about that 12th rib, just at that lower costal angle, and you're pressing down on the right. And you're going to press deep enough so that you can kind of feel if that liver slides between your fingers or not. And ask that patient to take a deep breath. And sometimes it just kind of slips through your fingers as you're pressing during their inhalation. It should feel like a very regular ridge, very firm, and shouldn't be nodular. But you know, most of the time it's not palpable at all. So it's okay if you can't feel it. You can also try the hooking technique. And this is when you are standing over the person's shoulder and you're hooking your finger upward at that costal margin. You have them take a deep breath, and then you can feel as they're taking that deep breath, that liver edge, it just kind of bumps your finger a little bit. And not that you're doing any measurement, but you just want to appreciate the liver is there, and you want to make sure that it's not enlarged or that your patient has hepatomegaly, so an enlarged organ. You can do the same with the spleen. Now you are still standing on the right side. And sometimes this gets a little bit hard to do. So I've seen some people actually try to do this on the left side instead, but you're placing your non-dominant hand, or excuse me, well, I'm right-handed, so I'm placing my non-dominant hand, but it could be your dominant hand, on the left side, again at that 11th, 12th rib area, and now you're pressing upward, and you can see it's just pointing right towards that axillary area. If you press deep enough, you might be able to feel the spleen. Nothing should feel firm, and you probably aren't going to feel the spleen at all. If the spleen is enlarged or they have splenomegaly, this is when you might be able to feel the spleen at your fingertips. So if you try it and you don't feel anything, that's actually a pretty good sign. You can depot your fingers together to find that right kidney at that flank area where you were testing for CVA tenderness in the back. This is where you would press together, and you're pressing firmly in your hands. You're asking them to take a deep breath, and then you can see as they take a deep breath, whether there's a change or not. And usually you don't feel any change, but if you're lucky, you might feel just that lower pole of the kidney slip right past your fingers. Again, it should be smooth and it should be um, not nodular or non-nodular. And if you feel it or you don't feel it, it's normal, but you shouldn't feel any nodes. It shouldn't elicit any pain. Note that your left kidney does sit a centimeter higher than your right kidney, and so it is even less palpable than your right side. I do want you to palpate the area of the aorta and try to palpate. You might not feel anything. You start just by palpating to see if you can feel the pulsation. If you do feel the pulsation, you want to just measure that pulsation area. It should be about 2.5 to 4 centimeters wide. Again, it depends on the size of your patient, but it should not be pulsating more than this. And if it is, it may mean that that abdominal aorta is enlarged. And again, I gave you a little allusion to this earlier, but you may be at risk for rupture or abdominal aortic aneurysm. Sometimes it's called AAA. There's some other special procedures here for advanced practice. I won't go through them in length. You can look them up in more detail in Jarvis, but these are ways for us to test to see if there are specifically appendicitis concerns in your patient. Not diagnostic, but can help you to understand if maybe appendicitis should be one of the differentials. Time to take another break if you'd like. You can pause the recording and come back when you're ready. Just wanted to pull out some more developmental competence here for you to review. When you're inspecting either a patient as an infant, note that they are going to be more protuberant, again, because of that immature abdominal muscularity. You're going to inspect their umbilical cord, making sure they have AVA, 2 arteries in 1 vein. And you're going to look to make sure that that stump is dry within about a week. It should fall off by itself. You shouldn't have patients pulling it off or patient families pulling it off. They shouldn't need anything to put on that area. It should dry off by itself and fall within 2 weeks. The abdominal is symmetric, although you might see some bulging. 2 different types of bulging that are normal abnormalities is the umbilical hernia, because that abdominal wall is not as structured. The hernia may protrude a little bit, and we probably see this about 2 or 3 weeks old, and it could last up to a year. If it lasts longer than that, there may be conversations about surgical repair, but it usually shouldn't grow as a concern. It stops growing about a month, and usually it's only about an inch or so. There's another common variation. It's called diastasis recti or recti, and this can occur in patients where the rectus muscle has a slight separation, so you see a little bit of a bulge. Sometimes it's more common with Black and African American infants, and then it will disappear in early childhood. Although I've seen this in the NICU across the board with different types of genetic backgrounds. So you may see it. I think I see it a little bit more because I was in the NICU and that's my major population, but it's not that common, but you may see some. For infants, you're going to do the same thing. You're inspecting, you're auscultating, you're percussing, and you're palpating, just the same. But think about the variations because of their size and differences in anatomy. You will also consider their constipation or their stool habits, excuse me, and there could be constipation in infancy and in the neonate. But the most important question for you in terms of a stool is, has your child had their first meconium? And this is their first stool. It's sticky. It's like greasy and very sticky. It's greenish black, and it occurs usually within the first 24 hours. Sometimes in utero it occurs, and so we're worried about that because your baby could aspirate that in your utero. That's a cause of concern. But also, if they haven't had a stool within 24 hours, now we're starting to think that there's obstruction, or maybe the GI anatomy, the pipes are not connected correctly. And so this is something that needs to be brought up quickly to the healthcare team if they have not stooled within the first 24 hours. Children, knowing that initially they're abdominal breathers, and this will remain something to consider until they're about 7 years old, and then they will start to build some more musculature, and you won't see that as much. So from this slide, that's the takeaway. You do see some protuberance as they're toddlers as well. I don't tend to test on the developmental functions of children in my didactic class, but things to remember and things to consider for third semester as well. Here you can help them relax during an abdominal exam. This is helpful for adults as well, but you can have them just, do some quick deep breathing into the palm as you're feeling, and getting them accustomed to just being touched and having your hands palpating. So for some children and adults, it can be a very ticklish exam. And so taking your time, having patience when you're doing this is going to take you a long way. Also, when you're assessing abdominal tenderness, remember that if you're asking the same question that you would an adult, they may not understand, what you're talking about. So try to use language developmentally appropriate, and you're going to learn again this more in third semester. But asking them, how does it feel may not be a good way to do this. So you might have to use a little bit more directed question, but also listen to them and see, how are they describing it? Maybe you just have to change your thinking a little bit about their descriptive words. When you are working with adolescent patients, they tend to be a little bit more embarrassed when their abdominal area is exposed. And I would even say, even 8, 9, 10-year-olds as well. And so giving them time to get adjusted to the notion that you are going to be performing an abdominal exam and that this area of the body needs to be exposed. I try to let them know about this beforehand and talk about the subjective history and then go forward, giving them a little bit of time to adjust. Now, with our aging adults, you might note that they're going to have increased areas of subcute fat, less abdominal musculature, and you might note that their just deposits of subcute tissue are distributed differently than a younger patient. Their musculature is thinner, they have less tone, and you might even have areas where you think it's should be thinner, but maybe a little bit more rigid. And these areas are areas of concern. Anytime you feel a rigid or board-like abdomen, this is concerning that maybe there is free fluid, maybe something's ruptured. So, thinking, it should feel a little bit mushier, but then it's not. This is something you want to bring up. It could be something acute. The liver in your aging adult is going to be more easily palpable. Normally you can't really feel that liver edge, but you might in an older adult a little bit more easily. And note that with distended lungs in an older adult, and when the diaphragm is depressed a little bit more, that liver can be palpated a little bit lower than you would expect in a middle-aged adult. Let's move on to the subjective, or excuse me, yes, the subjective charting for this week. Going back and thinking about the questions that you asked in the subjective history, subjective charting may look like this. States appetite is good with no recent change. There's no dysphagia, no food intolerance, no pain, no signs of nausea and vomiting. Your patient has a formed bowel movement a day. If you want to use the Bristol chart to talk about that, you can say that too. Number 4 on the Bristol chart. Takes vitamins, no other prescribed or over-the-counter medications, no history of abdominal disease, injury, or surgery. And you can talk about their diet as well, the last 24 hour, and you can put, eats all food groups, or whatever that diet history is. You can list here in the subjective. So a little bit more extensive than what you see here is what's expected in your charting. Go through thoroughly and ask in that interview with your patient today or your partner, and use this as a framework to do that. Objectively, you're going to organize it, inspection, auscultation, percussion, and palpation. So inspection, the abdominal is flat, so it's addressing the contour. It's symmetric with no apparent masses, skin is smooth, no striae, scars, or lesions. You can also add no abdominal appliances, like drains, surgical scars, etc. And then you're going to auscultation, bowel sounds are present. I would also add in all 4 quadrants, no signs of bruit, percussion, tympany predominates the 4 quadrants. The liver span is about 8 centimeters, right midclavicular line. You note splenic dullness, and the 10th intercostal space left midclavicular line. So you can leave those 2 things out if you're not going to test or try to examine the liver span or the splenic dullness. But at minimum, you want to address that that you have percuss and what sound predominates the 4 quadrants. And it may not be tympany in your case. It could be dullness. If there are areas of dullness you want to that are not expected over the liver and the spleen, you want to describe where that dullness is appreciated. And then lastly, palpation. You don't have to say, light or deep, but just say when you palpated, generally, here in a normal finding, the abdominal is soft. There's no organomegaly, so no enlarged organs, no masses, and no tenderness. Now, if you need to differentiate because you did find something, you might say, upon light palpation, was able to appreciate a 4 centimeter mass over the right lower quadrant, or you can say in deep palpation, noticed the liver margin is slightly enlarged, and this is where you would put that information. So if you wanted or need to, because it is what you appreciated in lab, to make a slight variation that's abnormal to this, you may have to do that. The rest of the slides are some abnormal findings. I would like you to go through and look at these things. I'm not going to spend too much time in the audio lecture today going through, but you will be tested on the different types of hernias, and be familiar with, if it's epigastric, where that bulge is occurring, where that defect is at, and whether it's umbilical or not. Here are some different abnormal findings of bowel sounds. There's a YouTube video that you can watch. There's a link in the slides, and you can become familiar with what that may sound like and give you a baseline. Like I said, you won't know if it's hyperactive or underactive, or hyperactive or overactive unless you listen to some bowel sounds. But remember, in the slides, it's about 5 to 30 per minute. Here are some abnormal vascular sounds that you can appreciate as well. Go through your Jarvis textbook to learn more about these, but I don't have examples of what they sound like. Then abnormal findings of enlarged organs. And finally, the summary checklist, going through what is expected. For lab, please review your checklist, or otherwise known as the rubric, or your head to toe assessment or your midterm assessment, and go through, and there it will more clearly outline what is expected of you in lab versus the increase in more detailed content that we went through today in terms of objective examination. Remember, look in the right upper hand corner of the slides in the objective area to see if this is a test that you are asked to perform or not, and it will correlate with your rubric for lab. Thank you, and if you have any questions, please let me know.